Well, good day, everybody. Great to see you all here. I hope you can hear me well.
Yes.
Yeah. Yes. Thanks, Ilka. Yes, very warm welcome to this workshop on integration of guidelines and quality indicators. We are very pleased to see you here. We had no idea how many of you would be here in this workshop. We didn't know whether it would be 5 or 500 people. We are now with 26. I think that is a very nice group in terms of with how many we are. Yes, I would like to start first with a quick introduction of the 5 of us as facilitators before we kick off with some introductions from you and the rest of the program. So we are pretty excited about this workshop, and for introductions, please, Thomas, can I give the word to you first for an introduction?
Hi, Miranda. Hi, everyone. Nice to connect and look forward to this session. My name is Thomas Piggott. I'm a public health physician and a researcher working on my PhD with Holger Schoenemann at the Mack Grade Center at McMaster University. And I've been involved in this work around quality indicators, quality improvement for guidelines with the European Commission as well. So nice to meet everyone and look forward to the session.
Thanks, Thomas. Luciana.
Hello to everyone. I'm Luciana Amciu. I've been working in the cancer area for more than 15 years and then joining the Joint Research Center for the European Commission Initiative on Breast Cancer. For the initiative, I'm working mainly for the development of the quality assurance scheme, namely requirements and quality indicators.
Thanks, Luciana. Elena.
Hello, everybody. I'm Elena Parmelli. I work with Luciana at the Joint Research Center of the European Commission on the European Commission Initiative on Breast and Colorectal Cancer, mainly involved in guideline development and the quality assurance part too. I'm also, since a long time, member of the GRADE working group, and I work for the Cochrane collaboration, so mainly involved in this stuff. Thank you.
Thanks, Elena. And Holger.
Hello, everybody. My name is Holger Schoenemann. I'm a professor at McMaster University and co-chair of the GRADE working group, and I'm director of Cochrane Canada. And thanks, Miranda, for having me.
Yes, and I'm Miranda Langendam. I'm based at Department of Epidemiology and Data Science, University of Amsterdam. I'm also involved in the work of the European Commission Initiative on Breast Cancer and Colorectal Cancer. And that initiative, that is, I think, where this work all started, and how to integrate guidelines and quality assurance. So first of all, we would like to know a little bit who we have in the workshop. And can I give the floor to you for that, Elena?
Yes. I'm going to share my screen. Can you see it?
Not yet.
Now?
Yes. Yeah.
Okay.
Now I can see
perfect. As Miranda said before, we didn't know how many people could be on this workshop. So since we thought having a tour de table was a little bit, well, it takes a lot of time, we have prepared a couple of Slido poll to know something about you. You can use this QR code to connect to the Slido, or just a second, I can also share a link if it's not possible for you to connect to the Slido in the chat. Here is the link. And so let's go back to this. So I'm launching the first poll. We would like to know, just to start, where are you from? Please answer, and we will see.
We start with an easy question.
Yes. Oh, we have some people from Canada and Brazil, but also from Belgium, Norway, US, Chicago. Okay, seems pretty stable. I will pass through the other question. We would like to know what's your expertise or your main area of interest. Okay, pretty straightforward. Measure development and guideline development. Family medicine, guideline development is the most common. Guidelines, public health, knowledge translation. Okay, well, guidelines win, but also public health. Okay, that's good. A very wide range of expertise. Onward. And then the last one, given the topic of this workshop, we would like to know if you are on the guideline team or on the quality indicator team. Oh. Okay.
And no worries, we will try to bridge the gap in this workshop.
Yes. Yes.
Yes, that encourages people.
Yes, quality indicators needs a little bit more people on the team, but let's see if at the end of the workshop we can go to a 50-50. Okay, that's it from my side, just to break the ice. Thank you very much for answering.
Yes, thanks. Yeah, I think it's good to have that last question again at the end of the workshop and see where we end up then. Thank you, Elena. Yes, I'm gonna start with an overview of all the concepts that we will talk about this workshop. But first of all, here you see some Dutch snacks, and I thought, yeah, maybe depending on your time zone, maybe you are craving a bit like me at this moment for Dutch bitterballen, or maybe the famous stroopwafels if you are in another time zone. So hopefully next time we can enjoy them for real. So like I said, I will start with a short overview of great evidence to decision framework, development of quality indicators, and of course the integrated approach. Then we take a deep dive into some examples from the European Commission initiative on breast cancer. First, we plan to do that in breakout rooms, again, depending on how much participants we had. But since only the main session can be recorded centrally, we decided just to stay in one group. We are with 36, so that I think that's perfect. And then the last bit of this workshop is to have some plenary feedback and how you can become involved or become involved more in the work that we are doing. Can I ask one of the other facilitators to keep an eye on the chat while I'm presenting? So yeah, guideline development, most of you are working in that field, are on that team. So very, very quickly, just to set the stage about guideline development. And what will appear here is the grade approach. So we have the guideline panel, and you start with formulating your questions and PICOs, selecting and defining your outcomes, prioritize the outcomes, then creating a summary of findings table for the estimate of effect, and you rate the quality or the certainty in the evidence, which can be high, moderate, low, or very low. I think most of you are familiar with that approach. 5 factors to rate down and 3 to rate up. So that is the first part. That is the evidence synthesis. And then in the second part, you grade the overall quality of the evidence. And we take into account the evidence, other evidence to decision factors. The guideline panel is, of course, involved in the various stages. And when you go into the evidence to decision framework, you make an assessment on the quality of the evidence, the balance of the benefits and harms, values and preferences, feasibility, equity, acceptability, and resource use if applicable. You balance that in the ETD framework, and then what you end up is a guideline with some standard formulations for the strength and direction of the guideline, of the recommendation. So this is just in 2 minutes, the guideline development process. So what about quality improvement and quality assurance? Well, we define quality improvement just to give you an idea of what it is for those working mainly on guidelines. The combined efforts of everyone, that is healthcare professionals, patients and their families, researchers, payer, planners and educators, to make changes leading to better patient outcomes, better system performance and better professional development. And that refers mostly to the process of improving quality. Quality assurance is a quality management directed to the creation of trust that requirements around quality are satisfied. And that mostly refers to accreditation scheme or other system. So quality indicators measure quality of health, they can be used to measure these requirements that I talked about in the previous slide. And they can be measured by examining its associated structures, processes, and outcomes. So we have 3 types of quality indicators, where structure refers to facilities, resources, organizational structure, and that is capacity to provide health, to provide quality care. Process quality indicators are indicators on communication about what kind of tests to do, what kind of therapeutic interventions to deliver. So it is about actual delivery of care. And then the outcomes as a type of quality indicator are about the effect of care on the patient's health status. what we and we all, I think, just referred to that in our introduction. We are all involved in the European Commission initiative on breast cancer, and guidelines are developed in that initiative and quality assurance. And in that process, we noticed that the quality assurance part and the guideline part were really two worlds apart. And we wanted to bridge that gap and to develop methods to come to an integrated approach. And we start working on a methodological framework to be used in the new European Commission initiative on colorectal cancer. Well, we did already some work. So one of the first thing was to make a systematic review, to develop a systematic review about approaches of integrating guidelines and quality indicators. We wrote a paper about bringing the two worlds closer together. And that is a paper, it is a paper about the critical analysis, like the title says, but it reflects the outcomes, the organization and the outcomes of a workshop that we held in June 2018. So that was already a couple of years ago. And then a third part of the work was to come to a conceptual framework of the definition of quality indicators, performance measures, and performance indicators. So this is all part of the work that we already did. And some more papers are coming up. So about the last paper, the definitions of quality indicators, performance measures, and performance indicators, we felt that was necessary to do that work because there were so many definitions and we have had so much discussion with the guideline developers and the quality assurance scheme developers on what do we mean by a quality indicator? What do we mean by a performance measure? And there are so many labels, so many definitions. So we sat together with a group of people, both from the guideline development and from the quality assurance, and we came to these definitions that you see here on the slide. So a quality indicator is a construct, and that is used to monitor, evaluate, and implement quality of services. Performance measures are tools to measure the quality indicators, to quantify or describe measurable elements. And the performance indicator is the threshold. So that is a measurable unit of practice performance. And in this effort to integrate, this is how we visualize to connect the outcomes to the quality indicators. So we have the outcomes in light blue here, and for each outcome you could define, or you can define, a quality indicator or more quality indicators, and then the performance measure follows from the quality indicator, and the performance indicator follows from the performance measure. Here's an example for quality of life. That is the outcome that you define as an outcome for the specific PICO question that you want to make a recommendation of. The quality of life is then the quality indicator out of the outcome type. The SF36 is the performance measure, and then a score of higher than 50 could be used as a performance indicator. Yeah, then of course you can debate the criteria for quality indicators. What are good quality indicators? And also here there are different definitions, different labels, but we brought them together to 3 criteria. That is for an outcome to be appropriate as quality indicator, the quality indicator should be evidence-based or scientifically sound, which means relevant, people, patient important, and of high certainty evidence, responsive to or sensitive to change, and feasible to measure, implement, and monitor. In our further work, we came to 2 approaches, and these 2 approaches are central in this workshop. So what we called the bottom-up approach, and this is, I think, maybe already a kind of jargon amongst us, so I'll explain. Bottom-up means that you develop the quality indicators and the associated measures by deriving them directly from the guideline recommendation outcomes. So this means that we have called this the guideline developer's perspective. And that starts at the prioritized key outcomes and questions, and that then you go via the recommendations and quality indicators, performance measures, performance indicators, to the quality assurance scheme requirements. So it starts with the key question, and it follows the flow of making a recommendation. So that is what we call the bottom-up approach, the guideline developer's perspective. Of course, we realize that there are already many existing quality indicators, and that there are also quality indicators that cannot be linked to recommendations, or maybe are not appropriate. We'll see. So we call that the top-down approach, and that is the quality assurance developer's perspective. So quality indicators and the associate measures, they can be selected from existing guidelines, quality indicator set, and quality assurance schemes. So it's existing, it's already there. So you start with collecting these quality indicators developed by others, and others in the sense that not by the guideline panel and quality assurance panel that are developing new guidelines. So you start with collecting these quality indicators, and you select them, of course, in a transparent and systematic way, to end up with the quality indicators that are relevant and useful for the topic that you're addressing. And in our discussion, in working with examples, we felt that, well, a quality indicator is always linked to a key question. It's probably always linked to a recommendation, and it can be very indirect. So we seek to also link these quality indicators with PICOs and recommendations. So that in that way we ended up with these 2 approaches, and of course they are in a large way complement to each other. Well, this is a very complicated slide, so I hope you're still with me. But what we wanted to show here are a couple of things. On the background, you see the care pathway in this example for the colorectal cancer, but it can be applied to other types of cancer as well. So it starts with prevention, the screening. Further down, you have the treatment, rehabilitation. So all these different domains you want to make recommendations on. And of course, a recommendation starts with a PICO. So for each of these domains, you want to end up, I can almost say, with recommendations, PICOs, quality indicators and the requirements. So these 4 blue circles are the elements that you want to have for each of these care domains. And of course, you also want some overarching requirements or maybe even recommendations. So let's say you're creating a guideline on prevention and screening, those domains. So you have the PICO prioritized, the questions and the recommendations. And based on that, you develop the quality indicators and the requirements. So that is those are the green arrows, the bottom up. But if you start for another domain which is not the focus of your guideline, you can start with collecting the quality indicators and work backwards to the PICO and the recommendations. And that are the blue arrows, the top down. So, yeah, as I said, probably very complicated, but we put this in just to show you how connected the quality indicators and the PICO and the recommendations are, and that you want to do that for each of the domains of in the care pathway. Now it's time after my short overview. I hope I didn't do it too fast. We'll see when we look at the examples if you have any clarifying questions. Let's have a look at some examples. And of course, we have these 2 approaches. We use examples from the European Commission Initiative on Breast Cancer. And first, we will take a look at how you go from a recommendation to a quality indicator. And what we will do because it is a workshop, so we expect you something to do something, is to have a discussion, and we have some questions for you. Of course, you can start any discussion on the topic that you like, or ask questions, or yeah, and be very critical. And I know that you are critical, have questions, and that is something that will only help to further work on this approach, and to use real examples to also to advance the methods in this field. And then, of course, the second part of the example that is about the other approach, the top-down approach, where you have quality indicators not necessarily linked to a recommendation. And we have 2 examples, I would say very different examples. Yeah, maybe I'll stop here a moment, just if you have a question that if you're really lost.
Miranda?
Yeah. Yes.
Sorry, it's Helena. Maybe just as introduction for the examples, since they are taken from the European Commission Initiative on Breast Cancer, we can say a few words on that, so to contextualize better the examples. And what do you think? Can this be a clarification that is good before starting?
Yes, yeah. Would you like to do that, Elena?
Yes, very quickly, just to say the examples that you are going to see and to discuss with us are taken from this European Commission Initiative on Breast Cancer, that it's essentially this initiative has 2 main goals. One is developing guidelines on screening and diagnosis of breast cancer. And the other one is developing a quality assurance scheme on the whole care pathway for breast cancer. So this means that the two parts are only partially overlapping. So the quality assurance scheme will be is covered by also the guideline produced by us only for the screening and diagnosis part. All the other areas of the pathway, means treatment, palliative care, and so on and so forth, are not covered directly by guidelines produced by us. This is just to clarify what we are going to see and why we decided to do all this work. This is it, just to introduce.
Yeah, thanks, Elena. I forgot to say that for you as participant that you have to click the Launch Zoom app to be able to turn on your camera and microphone. And of course, I should have said that before starting with my overview. Sorry, I forgot that. And then you have to go back to timeline. Fiona, just checking in with you. Did I say that correctly?
Yes, the instructions are on the screen just now. So if everybody could just follow those instructions to launch the Zoom app, then minimize the Zoom window to go back to the virtual conference portal, and then click back to timeline. That way you won't have two audio feeds.
And Miranda, there were a couple of issues in the chat just for you to know that we, I think, addressed, but just so that you have it.
Yes, I see them here. Lucia asked a basic, I think it's a great question. At what point in the guideline development are we creating quality indicators? And what's the connection with the monitoring criteria? Yeah, that is a great question. And of course, we talked about that, discussed that a lot. Like Holger answers in the chat, we suggest at the very beginning with the question formulation, but a little bit later in the example, we have a question for you as participants, but you have to think a little bit more about that. And that also covers the monitoring issue. I think that was the only question now in the chat. So I hope everybody found Launch Zoom app and back to timeline point. We now at 60 people. That's great. I just have to check in with Thomas. Do you want to kick off or shall I do it?
Sorry, I'm having trouble unmuting. Can you hear me?
Yes, I can hear you.
Miranda, I think it's okay if you want to kick off and I can jump in and help if you want, or whatever you prefer.
Yeah, super. So the first discussion will be about the bottom-up approach. And we have selected for this discussion, for this workshop, the question: should organized mammography screening versus no mammography screening be used for early detection of breast cancer in women aged 50 to 69? This was, of course, one of
Miranda, can you?
Yes, hi, Ilka. Yes, Ilka. Okay, I thought Ilka had a question, but yes, okay, maybe later. So this recommendation was one of the first that we did, of course, for the breast cancer guidelines. And this recommendation is a strong recommendation in favor of screening of asymptomatic women aged 50 to 69 with moderate certainty in the evidence. And of course, outcomes were defined, and that is what you see here on the screen. The outcomes were mortality, breast cancer mortality, all-cause mortality, stage 2A breast cancer or higher, the rate of mastectomies, the provision of chemotherapy, overdiagnosis, quality of life, false positive related adverse effects. And these outcomes were, of course, prioritized, so defined and prioritized by the guideline panel. The recommendation, like I said, was in favor of screening, a strong recommendation with moderate certainty. And yeah, also for this this recommendation, indicators were developed, and that was done in the quality assurance group. And this quality indicator is related to the recommendation. So that the quality of the requirement is called the SCR4 in the quality assurance manual. And here the statement is women age 69 must be invited for mammography screening as part of the program. They also defined the quality domain, clinical effectiveness, and the process. So this part, these few slides that I'm going to show you are from the quality assurance manual. And here you see the indicator for this statement. And the quality indicator is the measurement of compliance with this requirement in the quality assurance scheme. And it's a number of asymptomatic women aged 50-69 who were invited for screening within a screening program, divided by the total number of asymptomatic women aged 50-69. It was a process indicator. And you see the target population and also the norm, so the performance indicator. And for the data source, you see that is the guideline recommendation that was developed within the same European Commission initiative. So in this example, this is an example of the bottom-up approach where the quality indicator and requirements are really connected in the recommendation. So it goes hand in hand. And just pause for a moment whether Elena or Luciano or Thomas has something to add or to give some context maybe on the quality indicator.
Well, maybe I can start and then Luciana can go more into the detail of the work on the requirements and the quality indicators. Another thing that can be of interest is that in this project, the European Initiative on Breast Cancer, there were two separate panels, one working on the guidelines and the other one working on quality indicator. That is something that maybe can be useful also on the discussion. So this was let's say a bottom-up approach because they were taking the evidence directly from our recommendation. But the two groups were not the same, were working in parallel, let's say. And no, that this is just a context comment, how these things was developed. And I don't know if Luciana wants to add something on the structure of the part of the quality assurance with requirements and quality indicators and so on.
Yes, just few clarifications, because in the slide you see also other recommendations from the guidelines, for example, for women from 40 to 45. So the quality assurance development group decided to take and to have requirements and subsequent indicators only related to the strong recommendation. So meaning from 50 to 69 in this particular case.
Yes, thanks. Yeah, what I also want to show you, and then I'll do that in quickly in another document, is to show you the evidence to decision table in this case for this recommendation. And for those of you who are familiar with working with evidence to decision frameworks, you probably recognize the different factors. But the guideline panel judged the desirable effects of screening 69 women of 50 to 69 as large. Desirable effects were large. The undesirable effects were judged as moderate. The certainty of the evidence was also moderate. And the values for women invited for the screening were possibly important. There was possibly important uncertainty or variability, meaning that possibly not every women would place the same values on the desirable and undesirable effects. But if the guideline panel balanced the effects, the desirable, undesirable effects, then they came to a judgment of favors the intervention. The resources that were required were assessed as moderate. The certainty of evidence in the required resources was low, so there was some uncertainty. The cost effectiveness of screening this age group was probably favors the intervention. Equity was judged as varies. Acceptability, so it was screening this age group was considered acceptable and probably feasible. So taking these factors all together, that was how the panel came to a strong recommendation for the intervention. So that is good to know, to keep in mind when I go to some questions for discussion. So we have this recommendation, we have this quality indicator. And remember that we're now talking about the bottom-up approach, or the guideline developer's perspective. So the indicator was a process indicator, proportion of women invited for screening. And then, yeah, one of the questions that we have for you is, how would you assess the certainty of the evidence in this process indicator? And yeah, just in a brainstorming way, what elements can you think of? Of course, when we think of risk of bias, inconsistency, indirectness, imprecision, publication bias. But to give you a hint, maybe indirectness, that is something I'm particularly interested in. So you can either put your thoughts in the chat, or it's also fine to unmute and share your thoughts with us. So for this particular example. Or if Thomas or Holger, or if you have any pointers maybe for the others.
Well, I think what if Thomas is not coming on, I think what is probably relevant in this context is thinking of all the steps that you described, right? You said, where in the ETD would you like to see the quality indicator info, which is our main question based on that example. So I think I would suggest the audience think about, is that in the beginning? Is it throughout? Is it at the end when you implement a recommendation? Right. Those are some key aspects. Then again, the information can be integrated in the ETD in the criteria that you described, or it could be, as you just also emphasized, in the implementation considerations, right? So just to kick this off a little bit more, perhaps. And there is a question in the chat.
Is the denominator, is that, Sarah, is that a question or a discussion point? Is it a clarifying question or something you would like to discuss? A discussion point, yeah. Is the denominator clear? Yes, clarity is important, but also is it fit? Does it fit? Does it have a good? Does it fit the PICO? I hope you understand what I mean. So any thoughts?
We have also a hand raised by Lucia. Maybe we can take that question too.
Yes, Lucia.
Hello, can you hear me?
Yes.
Yes. Hello, good to see everyone. I thought about these questions, where to see the quality indicator information, and I think it depends on how we are using the quality indicators and like at what point we are working with them. And I must say, I'm not familiar with this. This is very new to me. So this is why I came to the workshop to find out as much as possible. And it just makes sense to me to have it at the in the monitoring criteria or somewhere there, because it seems like it's related to the recommendation after it's been formulated. Isn't that so?
Yes, and can you think of an example yourself, Lucia, or is it?
No, this is new. These things are really new to me.
Yeah.
I would actually like to hear maybe even more on like on the background of all this and your thoughts when you were coming up with with the presentation. I'm not sure, maybe I'm not the only one who is.
Oh, you're probably not the only one.
Just the bravest.
Yeah, exactly. We also had some people who said in Elena's question said yes to I'm on the quality indicator team, so to say. If I invite one of you who said quality assurance team, if you can think of examples that maybe you have worked with, or and we're looking especially for whether you want to put it in the implementation consideration or the monitoring and evaluation. Maybe you want to have it weigh in the values and preferences. It can be maybe at many levels, resources. So
yes, I think that for sure the fact that the information on the quality indicators selected or identified should stay in the monitoring part of the ETD. Yes, I think it's quite sensible, because there you can put, well, at least in my opinion, a lot of information on how to measure it, all the part of the performance measure and so on. But I don't know if someone else, for example, thinks that something before that part, that is the very last, when you go through the development of the recommendation, you arrive at the monitoring and evaluation consideration at the very end. If something before should be said, for example, if following the scheme Miranda showed, we have to identify the quality indicator starting from our PICO question, the outcome of our PICO question, maybe something can go also in the part when we describe the PICO in the background. I don't know, at the very beginning. Is it something that could be of help? There are a lot of comments and questions in the chat. I don't know if how we can deal with that. It's
yeah, there is a comment of Ilka. Holger, can you take Ilka's question?
Of course, I can try. Okay, so Ilka's question refers to that the quality indicator will differ by possible age groups, and I think that's entirely correct, right? So, but the way to address the question most appropriately, I think, is if you develop different recommendations for different age groups, the quality indicators need to be related to the recommendations that refer to the specific age group. So if a guideline, like in this case, makes a recommendation for 50 to 69-year-old women, the quality indicator should refer to that age group, because the recommendation implies, in particular with a strong recommendation, implies that there are no subgroup differences, right? So under those circumstances, probably not helpful. But when there are subgroup effects or different recommendations for different subgroups, then it would make totally sense to make separate or issue different quality indicators for these other groups. So for instance, a conditional recommendation for a younger age group or an older age group might lead to different quality indicators. They may be entirely different, right? There also is the question by Karen that I think is very interesting. Miranda, I don't know if you had a chance to see that. Which I replied to in the chat, but I didn't hit enter yet. Do you want to address that perhaps?
No, just tell us what you wanted to put in the chat.
Okay, so I think, Karen, that sounds like a very solid process, right? So Karen is saying, as a guideline developer, we are using measures only that are based on strong recommendations and that come with moderate or high certainty evidence. That sounds very solid, right? And is very different from what many other groups have done in the past. But I would ask another question. What would you do if there's a conditional recommendation that actually lends itself to shared decision-making? You know, is there a way that you can think of including this particular recommendation such as that, a conditional or weak recommendation, as a quality indicator? Question to the audience, perhaps, or back to Karen. Can you imagine that scenario?
Olga, I would also add something on the comment that Karen said, that one characteristic that a quality indicator should have also to be implementable is that it's measurable. So I think, and maybe my colleague Luciana can add more on this, that obviously the participation rate would have been the best, let's say, indicator to be identified to measure this process requirements that we were developing. But if I remember correctly, and Luciana can help me on this, the panel decided not to use that because they, according to what was available, it would have been very difficult to measure it in the screening program, at least in our context. So that's why we decided to go for, let's say, a surrogate. I don't know if this helps also in the discussion.
Also, I would like to add an information that the quality assurance scheme was developed for services, meaning that you have to decide on indicators that can be influenced by the service itself. So in our case, the indicator is proportion of asymptomatic women aged 50 to 69 who were invited for screening within a screening program. I hope it clarifies. We have another hand raised by Emily.
Yes, Emily.
Hi, can you hear me?
Yes, yes.
Okay,
Thanks.
great. Just a few things, actually. So for the ETT, where to put the quality indicator, does it matter whether it's top down, bottom up? Because if you're looking at specific evidence for the quality indicator, then that would have to be put somewhere and evaluated. And then, yeah, I had the other question about the proportion of women. I was wondering why it wasn't how many women accepted to be screened. And then I was thinking about, you know, how you evaluate prognostic information and looking at what's rather than, you know, a very specific that you would find in RCTs. So I was wondering that maybe looking at the certainty of evidence, you would want to make sure you captured as many people as possible when you're assessing the certainty of evidence. So those are just some of my comments.
Yes, great comments, Emily. I think your first one was, does it matter whether it is bottom up or top down for the quality indicator? I don't think that matters. It's more what your, could you say, source or your approach is. So I personally think it doesn't matter. And what is, I think, also good to mention that in the quality indicator, as I just showed you on the slide, it was the proportion women invited. We also talked about, and we see that a little bit later, about the participation rate. What was stressed very much in the guideline panel, in the breast cancer guideline panel, is, and I think Luciana also said that, that the ideal indicator would be the proportion of women making an informed decision to participate. But that is, I'm not sure whether I think we looked for that, but it is just very hard to find because that isn't measured. But that would be, of course, the ideal measure for this. So, and that is why I pointed a little bit in the direction of indirectness. I think that is one of the factors that we should take into account when we want to assess how certain we are about a quality indicator. But now maybe I'm drifting a bit off. Yeah, that's so. Thanks, Emily, for those points. You wanted to say something else, Emily,
No, that's, yeah, I can see how that would relate to indirectness. Yeah. That was my first thought too. It's like, oh, why were you looking at that instead of the other one?
Yeah.
But yeah, that makes sense. Thanks.
Okay, thanks. I do not see other raised hands, but
there's a discussion going on between Olga and Ika on the performance indicators value and having a quality indicator on whole the age range. I don't know if the two discussing want to summarize it for the others or.
Yeah, Ilka, do you want to?
Yes,
to say
okay, thank
it?
you. So I was just commenting that even if you do not define a PI value, for instance, a proportion, how many people should be invited or attend, you should monitor the quality indicators for all recommendations just to identify variability between regions and observe trends. And that could even be a surrogate measure of how many women make a decision to participate, even if we don't know whether that was an informed decision. So if you make recommendations and if you have the technical ability to monitor how well they are followed, you should monitor them all. I think that would be important information also and feedback for guideline developers of the value of giving such recommendations, even if you don't know what the PI would be.
Can I add something on this? I mean, the other, if I can start. Yes, Ika, thank you very much. This is very important. And that's what I was thinking when we were working on this and related the quality indicator directly in the recommendation development process at the very beginning. Yes, at least my idea is that if every time you develop a recommendation, you think from the beginning of possible quality indicators that relate to that, then they are sitting there in your ETD, and you can use them if needed or not. Why I'm saying or not? Because as Luciana, my colleague, told you before, for example, our specific quality assurance scheme for this project was developed for services to, let's say, monitor the quality of the services of breast cancer and in Europe. So this quality assurance scheme should have specific characteristic also of being applicable, you know, because if you give a service hundreds of quality indicators to measure, you just can check and give them a certification or whatever you want to give. But if the quality indicator is there, when you develop your recommendation, can be used in many different ways. Even if we would have not included it in our quality assurance scheme, it could have been used by someone else to monitor, for example, regional tendency, as you were saying. I don't know if it makes sense also for the others.
Yes, thanks, Elena. Any other thoughts? I was looking again, Karen, at your comment, and you write, we expect the guideline group to complete the recommendation and tell us if it's strong. Do you have experience, or would you like to get experience in going through this process together, so that you as a measure developer are also involved in making the recommendation and the other way around? So
yes,
yeah, in collaboration.
So, this is Karen. Just to clarify, I'm currently, literally today is my first day at GI Quick, but I've been in plastic surgery for the last 5 years. And before that, I was at PCPI and then at pediatrics for 10 years doing guidelines before that. So I actually am one of the few people who have experience on both sides of this. And one of the things that I think is so important, and the reason I'm still coming to GIN, even though I've switched to measure development, is that I think guidelines and measures have to work together. You have to start thinking about what you're going to measure from the time you start the PICO question and defining the outcomes and developing the recommendations. If you don't, it makes the measurement side very, very difficult, especially if things aren't well defined and aren't actionable. I actually did a session at the GIN meeting in 2016 on why you need actionable recommendations to develop performance measures. So.
Yeah, thanks, Karen. That is exactly our point, and thank you for the example that you put in the chat. And that inspires me to specifically look for us as as team, as researchers, for examples of shared decision-making measures, because there must be more, and that helps us to understand how they are different phrased than quality indicators that are based on that are other, so not they're always based on shared decision making, but when you have a strong recommendation, it's another type of quality indicator than the shared decision making. I'm babbling a bit. Just looking at the chat. Yes, we need you involved in our great working group.
I'm happy to join.
Yeah, super. Any last thoughts before we go to the second approach? So where you don't start from making the recommendations, but probably go the other way around. And we can always come back, of course, to this approach if the discussion needs that.
Miranda, maybe we can ask Karen to explain her example and maybe can liaise to the other question we wanted to, I don't know if this helps, if she would like to, maybe discussing the example she put in the chat can help in bringing up other questions or other comments useful for this part of the process.
Yeah, is that something you would like to do, Karen?
I'm sure, I'm happy to do that. I guess I need a little more guidance. What do you need me to explain, or what should I break down?
No, for example, which was the type of process you followed to arrive to that? If you do a structure way from the beginning, I don't know, because I don't know if everybody needs the chat, so just to share with everybody there.
I guess it's a worldwide crisis, but in the US for sure, we have an opioid epidemic, and every set, and especially in surgery, we were trying to avoid prescribing as many opioids as had been done in the past. And so while we weren't quite ready to say you can't prescribe an opioid for rhinoplasty because it can be painful, and there's people who are allergic to NSAIDs and et cetera, we were trying to come up with an approach that would allow us to discuss non-narcotic strategies that would be effective so that we would get to that place where we reduce opioid dependence or opioid prescriptions. And so there was a guideline done by the AAO-HNS. When did we do this set? I think it was published in 2016. And it was just before all the evidence was kind of finalized around opioids. So they didn't come out with a recommendation, but we had their chair people on our measure group, and they said, had we had one more year, we would have had a recommendation that said, don't give opioids. So this was kind of our compromise. And so really it's just about making sure everything is measurable and definable. And so we're looking for, so the documentation gets to be tricky because a lot of documentation is done in the free text. So we just try to give some guidance around that. Our denominator for the whole measure set was percentage of patients aged 15 years and older who had had a rhinoplasty procedure. So we're always looking back at patients who've already completed their surgery when we're measuring, and then looking to see who had documentation of a preoperative shared decision-making strategy. And then they had to document that they talked about 2 pain management options, one in the non-opioid analgesic, so systemic, and then one in the non-systemic, such as ice or cooling or elevation, rest, mindfulness, meditation. And they had to pick one. In this particular case, they had to pick one from each category. We went on to do a similar measure in our reduction mammoplasty set, which is breast reduction for those who aren't familiar. And they weren't quite ready to say you had to do a non-systemic. So in that case, we just put together a list of non-opioid strategies and said you could pick 2 from the list. But we've been using this model in a couple of different places. Is there specific questions?
Yes. So, well, I don't know if I'm getting it right, but so you started from the need of having a quality indicator, the measure, not the recommendation, right?
In this case, yes. In most of our cases, we tried to start from a recommendation, but we didn't have.
Okay. So this pertains more to the approach that we are going to explain after. That is what we defined the top-down. So you didn't start it directly from the people question for the recommendation, but you started from identifying your quality indicator or requirements, whatever, and then looking for evidence to support it. This is what I understood. Right?
Yeah, in this case, I guess that would be true. There was some discussion in the guideline of avoiding opioids. They just didn't quite raise it to the level of a recommendation because it was a little bit too soon. I think in their revision, they probably will have a recommendation.
Yes. No, yes, but this helps also because it relates more to the other type of approach. So not starting the one that Miranda was going to introduce when I stopped her. So that's very good. Thank you. Thank you. No, was was very useful to have this explanation. Thank you very much.
Mm-hmm.
Yes, thanks, Karen and Elena. There was also a comment from Paul van Rooyen in the chat. I just pronounced it in a very Dutch way. Paul says, I agree that guideline developers should be involved in the guideline development from the beginning, but should they be involved in all phases of guideline development? Yes and no, but that is something we will find out and I think further investigate in upcoming projects that we're doing. But that is a very relevant question. I think that the expertise of the quality indicator, the quality improvement developers is very important in the whole process. So we will see in our upcoming projects how to involve everybody in also in an efficient way. I think that's a very exciting part of everything. I'm also looking at the time, and I want to proceed to the other approach. Elena, Luciana, can you introduce that? And I can do the slides for you.
Yes, I will start and then Luciana will go into the details of the requirements and quality indicator developed for this. As I was saying before, in our project, there was a part of the quality assurance scheme that was covering all the care pathway of breast cancer that was not covered by the guidelines recommendation that we developed internally. And so for developing this part of the quality assurance scheme, we started in a similar way that the one just explained by Karen. So identifying, starting from the requirements, so the type of needs we wanted to be covered by the services. And for each requirement, identifying a quality indicator, existing or not, and finding the supporting evidence to include this quality indicator for the measure of the specific requirements to be used for the quality assurance scheme, so for the certification of the service. Here, will we report on one specific topic that is training, where there are requirements on this. And Luciana will go into the details of that. And this in our, let's say, methodological framework, the one we are working on for colorectal cancer, it's called the top-down approach. So starting from the requirements and quality indicator and not from the recommendation development. And we have tried to explain it, telling that here we have a sort of more quality assurance perspective, in the sense that we are the ones that want to identify the measure, not starting from the development of the recommendation. So I give the floor to Luciana to explain a little bit the history of these requirements on training. Thank you.
Thank you. So first step was to prioritize the professionals that could benefit from such a requirement, and the working group acknowledged the involvement of many professionals, but at the end, after the prioritization process, 10 professionals were prioritized, among them radiographers working in screening programs and for diagnosis, breast radiologist, pathologist, surgeon, and other professionals. Requirements from other schemes, from databases, and other type of literature were systematically searched, and the guidelines development group rated the requirements for understandability and then for feasibility, and ended with a requirement that says that the breast cancer service must ensure that healthcare professionals are qualified and competent to deliver the service. And then there are explanations on what this means for each professional that was prioritized.
You want me to skip to the slides?
Yes, please. And then here it's a description with some characteristics that should be have the different professionals. Of course, also for these thresholds that are in the table, evidence was searched for, and what was found, as in the
we lost the voice.
Yeah,
we can't
hear you anymore, Luciana.
I don't know what happened.
No.
Well, while Luciana can reconnect, I can just add that if you go back to the other slide, the pink one, yes,
the pink one, yeah.
Yes, so this just to go back to your previous slide when you were describing the different type of quality indicator. This one on training is considered a structure one. So if you go to the pink one, yes, it's related to the capability of a specific structure to provide training to the professional working in that, and this is considered a quality measure of the quality of the service. And this the fact that this is a structure indicator has to do also to maybe to what was introduced at the beginning, the difficulties of finding a specific recommendation that can relate to it, because it's not so easy to have a single recommendation on a topic like that. So maybe here you have to find another strategy to identify your quality indicator, and maybe you can just go back to the recommendation. I don't know, Luciana disappeared. So in particular, this discussion, I'm sorry, because she was the one following it, so she could give more detail. The discussion of the panel on that, well, they looked for evidence for the single professions, how much time they should have been trained, and so on. And in the end, they relate on other evidence using supporting it. One of the sources was a good practice statement that we had in our guidelines on the need for training for different professionals involved in the screening program. So this is something that I think can be of interest to be discussed in this group, because we were talking about strong recommendation and linking quality indicator to a strong recommendation. But what about, as in this case, having a quality indicator and a requirement linked to a good practice statement or other type of supporting evidence? So this is something that can be discussed starting from these examples.
Yeah. We have, thanks, Elena. We have 10 minutes left in this workshop. Time flies. Thomas or Holger, is there anything you would like to add, or for this last? We had some discussion points here, but
yeah,
maybe you have other ideas.
Well, we were just thinking, so there's discussion points if people want to unmute themselves and share, but I also put a question into the chat if you can see it. And it's just thinking about examples of guidelines that you've participated in. I'm wondering, is there a possible quality indicator and performance measure you could think of? And maybe we can just take the last little bit here for you to think about a guideline recommendation and then into the chat so that other people can see examples, right? What the recommendation was and then what potential, even if it's just theoretical at this point, quality indicator and performance measure would be. I think it'd be nice to finish in a bit of an interactive way there. And if you want to also put up your hand and share it verbally, I think that's great too. I don't know, anything to add to that, Holger?
No, nothing to add to that particular point. I think we have a few minutes, as Miranda said, as people are thinking, to answer questions and to summarize a little bit. So there's a question from Greta. How much of the implementation strategies can influence the control and management of quality indicators? I read a little bit into this question. I want to make sure that I understand it correctly. I guess what you are referring to is feasibility of the quality indicator. That's my reading of the question. So in terms of the implementation strategy for the actual intervention may relate to the possibility or the feasibility of measuring the actual quality indicator. If I did not understand your question correctly, then let me know, Greta. There's a second question from you. There's some uncertainty who should be in charge or control and ensure that the PIs and the quality indicators really work. Maybe Luciano or Elena can take this. Otherwise, I'll be happy to try to give that better shot.
Yes, well, I think it depends in the sense that quality indicators and performance measures can be used in different ways. For example, as far as we are concerned with the quality assurance scheme, once the quality assurance scheme is done and it's out, it's on our website with a manual, the institution that wants to be certified with that should apply all the list of quality indicators and requirements that are in the manual, and they will go through a process of piloting and auditing, and someone will check that these quality indicators and performance measures are reach the suitable thresholds. This is from the quality assurance point of view. Then quality indicators are used in many other different ways. I don't think it's in charge of the panel developing the guidelines and eventually developing quality indicator attached to specific recommendation to check the implementation or application of that. For what concerns if the quality indicator really works for measuring what you want to measure, a group working with us in our project has done some work on that, trying to see if the quality indicator really correlates to an improvement of the evidence. I think that, I don't know if Miranda, you are sharing the papers that we have used to prepare the workshop, but the paper on the monitoring and evaluation group is public, so maybe we can share with the participants if you want. And there's work on that. I'm not sure about who should check this, but if the characteristic that we listed for quality indicator, that's also scientific soundness. So in a way, when you are selecting it or identifying it or developing it, you should also check that as a scientific, it's evidence-based, it's scientifically sound to measure what you want to.
Eleanor, just in terms of who should check it, those are typically those who are certified in quality assurance, right? Those are the groups who probably need to check that to answer Greta's question. I'm thinking, you know, there's about 6 minutes, 4 minutes left. Sorry about that. So I'm going to share my slides for everybody else in just a second. Thomas, let me just take this over. It said put something in the chat there. Okay, so I'm going to share my slides here. There's a couple of things that we wanted to go through with you. First of all, that there's ongoing work with the various groups that we are involved with that we can follow up on, and there's some good questions from Caroline that I asked Miranda possibly in the meantime to address. But we wanted to share a few things with you. The first is a sign-up sheet for anybody who wants to stay involved. And so for instance, Therese asked the question to share material and resources. This would be a way to get to any material and resources that relate to this workshop, right? And then the second link that I'm just gonna show here, and that I'm gonna ask one of my colleagues to post in the chat is sign up to the GREAT working group, and I'm gonna show this for a second in terms of how this actually works. That way you can see if you're really interested in developing the conceptual framework a little bit more, and if you're interested in producing guidance around that, then the GREAT working group might be the right platform for you. And this is our sign-up sheet. Again, I'm going to ask Thomas possibly to put this link in the chat. If you can, Thomas, our sign-up sheet, you would go to groups 26. This is for the GREAT working group that has many project groups. And just down here, easy enough, you search for sheet 26. You can get involved. You can just leave a comment here anywhere. And Miranda, Thomas, and Ellen will follow up with you, or one of them will follow up with you. So that's the second group. And in order to be fully involved, it's best probably to get on the GREAT mailing list in general. That's how we communicate then across the different project groups, and you might want to sign up there as well. And that link I will show you in just a second. That way you can actually follow up with us about GREAT. But this was just before everybody leaves, that I will put this last link in the chat. That way you have all three of them. Don't get confused between them because it's very easy to get confused, but you have them there in the chat. You can just click on them and put them in your bookmarks. So for the last 2 minutes, just perhaps a very brief summary. I think what we've heard is first of all, about some really interesting examples. And I thanks to Ilka, thanks to Karen there for sharing these examples that are extremely helpful, I believe, in moving forward. And people are putting in some additional examples, which I think is really good in terms of moving this work forward. We've, I think, seen already examples that are in line with many people's thinking, where we have oftentimes strong recommendations developing into performance, into quality assurance, that includes quality indicators, but there is a room for conditional recommendations, or when a guideline panel is not so sure, to also use conditional recommendations, and in particular issues around shared decision making as a quality indicator. And it's good to see that there are groups that are already doing this, because I think that will be doing away with one of the big misunderstandings. And then perhaps the most important piece is that it seems like this group fully agrees that quality indicators should be based on good guidelines. And I think that's if we can communicate that through more collaboration to those who develop measures, I think that would be a big advance. So these are our 3 links that are relevant for today. So you can stay involved in whatever way you want to. Miranda, Thomas, and Alan, I can possibly talk more about how this great project group actually works a bit, here. So over.
Yes, thanks, Holger, for this summary. Yeah, I think I hope everyone will leave their name and email for us so we can keep you informed. Use the other links. The way we work in the Great Project Group is that we will set up regular meetings over the year to work on, to begin with, a great concept paper, later great guidance, and everybody is very warmly invited to contribute to that. And I think the Great Project is the place to be to keep on track with what we do. It's 2 minutes past the time, so I would like to thank Luciana, Elena, Thomas, and Holger for co-facilitating this workshop. I want to thank everybody for participating, 45 people. That is really great, and we hope to see you on other occasions and to stay involved and to share your examples. Of course, we will save the chat and the recording, and also the recording will be made available for you guys to maybe listen again to this interesting discussion. So thank you, everybody, and enjoy the conference for the remaining days. Enjoy the yoga session later on today, and I will see you tomorrow or the day after tomorrow on another meeting, other occasion. Bye bye.
Thank you, Miranda. Thank you,
Thank you.
everybody.
Bye, everybody.
Bye. Bye.